Greetings from the United States. This is Gerald Samson in Atlanta, Georgia, USA, inviting you to attend the OVAP 2015 meeting, June 25, 26, and 27, to be held in the Netherlands. This is our yearly OVAP Congress meeting. Make note of this 3-day conference, and the location is quite beautiful, remote, and relaxing. I'll be speaking with you for 3 days. This presentation is meant to highlight the main meeting, which is on Friday. These are our sponsors for this year's meeting. We welcome our sponsors and encourage your purchases from these people that have supported the OVAP organization. Ask yourself this question: why should a parent select you rather than someone else to treat their child? Certainly, this has to rely on your expertise in mixed dentition. This is what our meeting will concentrate on Friday, June 26th. Mixed dentition, age-appropriate orthodontic treatment in detail. We have clear objectives that will be outlined on the Friday main meeting. This is a full-day meeting. And the purpose of interceptive orthodontics is to improve the situation that we see. Mixed dentition orthodontics is designed to improve, not fully correct. It is designed to avoid severe problems. So, for example, I explained to parents that what we do not want to do in modern orthodontics is wait until things have gotten as bad as they can possibly get before we do something. I will hand out 4 key opinion considerations. These are my opinions about the things that would help us guide into the decision to treat in the mixed dentition. There are 4 key objectives that will be covered in detail. First on our list will be this very interesting 8-year, 2-month patient. He has been observed by his pediatric dentist for quite a few months. What is your impression of his facial balance from a frontal view and profile? What is your impression of his lip posture, of his lip seal? Do you think if you look inside of his mouth he is class 1, class 2, or maybe class 3? He presents with what is termed a simple open bite. There are 3 classifications of open bite. This is of the simple variety with the best possible prognosis. He presents with a class 2 posterior occlusion. Examine the amount of spacing or crowding that you see on the upper and lower arch. His panoramic film presents in 2004 with this type of appearance. We will be going over this in detail with a team approach, similar to what we did at last year's 2-day Congress meeting. Cast analysis shows a full class 2 posterior occlusion with anterior open bite. What are you thinking about the stability of correction of the anterior open bite and the etiology? There is not an active digit habit. In fact, the parent states that there was never a digit habit in this case. I will not be teaching a cephalometric course this year. However, I will briefly discuss the implications of the cephalometric analysis for each patient that I'll show. How would you be thinking about treating this case? What options and what treatment sequence would you be thinking about? In typical Dutch fashion, we will have a festive, if not vigorous, discussion leading to conclusions and consensus of opinion about treatment for this type of case. I'll be handing out a detailed manual. The manual will include different literature references about open bite malocclusions and the problems that they present. This pediatric dentist had been waiting for 6 to 9 months for the bite to close, which was not progressing well. Therefore, after trying to treat conservatively for the open bite in the class 2, I changed to a series of fixed appliances using what are called additive force mechanics. You'll be seeing this in hands-on appointment-to-appointment detail, exactly how I adjust the arch wires, and these arch wire adjustments are done intraorally. Intraorally, the arch blank is taken out of the box, placed into the patient's mouth. All adjustments for these open bite closure mechanics are done intraorally, but perhaps the patient won't show good stability. Here is the patient 2 years after all orthodontic treatment. He was treated in 2 phases. In the first phase for the class 2 and the open bite. Then he had a retention phase, and then a very brief full treatment phase in the permanent dentition. You can decide for yourself about any facial balance change. You can decide for yourself if you agree with what you are seeing aesthetically. If you agree with what you see, then you like how I treated the case. If you don't agree with what you see, perhaps you would differ. Here will be one of our next patients. This is a 9-year, 4-month patient with a positive history of infrequent headaches. What do you notice from a frontal view, both smiling and relaxed? Do you notice anything unusual? Do you? Look carefully. Do you? Well, this patient actually has a true asymmetry, a true dental alveolar and skeletal asymmetry. We will be talking in detail about which of these can be corrected with orthodontics only in a conservative method, and which of these would actually require orthodontic surgery in order to correct. Which of these will get worse with age, which might improve with age. This picture is not made at an angle. This is actually her asymmetric malocclusion. And if you look carefully, what do you see? OVAP, what do you, yes. On the right you see a posterior crossbite. On the left you do not see a posterior crossbite. This patient has no significant mandibular shift. How do you know that I'm accurate about that? Examine her canines. Examine her canines. They are not in crossbite. So any shift to the patient's right would be quite mild in nature. She has a true asymmetric crossbite. How would you treat that case? A true asymmetry. How would you cause asymmetric mechanics in order to correct this type of case? These are fairly unusual cases. Here is the patient when she's 21.5 years of age, 4.5 years after all orthodontic treatment. None of the patients that I'll be showing will have fixed lingual retention. They all have removable lingual retention, which I will discuss in detail. Do you still see an asymmetry? If so, where? If so, why? Which asymmetries can be corrected in a predictable and stable fashion, and which cannot? You notice a reasonably stable occlusion, 2.5 years out with no fixed lingual retention. How do you think that case was treated? This patient will be shown in appointment-to-appointment detail, including literature support. Since our meeting on Friday, the main meeting for the OVAP Congress, will focus on mixed dentition treatment, I'll show this type of very highly simplified anterior alignment. This is done with segmental arch wires. These are exceptionally simplified mechanics. So you'll notice that the middle picture is after 4 weeks. The next picture in your lower right-hand corner is the following visit after an additional 4 weeks. So from the upper left to the lower right is a total of 2 office visits, or 8 to 10 weeks of treatment. You'll be seeing a hands-on scenario of how these mechanics are done. Of course, it's rather important to avoid impinging the roots of the laterals on the developing canines. For that, I have very interesting and simplified hands-on mechanics for you.
You ain't nothing but a hound dog.
Ah, classic American rock and roll. You ain't nothing but a hound dog, baby. You snooping around my door. Of course, we'll be talking about crowded cases, extraction, non-extraction, and the difficult borderline case. We will be discussing these in detail with literature support. This will be one of the patients that will exemplify that particular treatment option. A 7-year, 3-month female. What do you see from facial balance smiling and at repose? What do you notice from a profile view? Do you think when you look inside of her mouth she will be class 1, class 2, or unlikely, class 3? What do you think you will see when you look inside of her mouth? She has a transitional open bite in the mixed dentition. Maybe surprisingly, posterior occlusion is class 1 and never treated. When does that happen? Why does it happen? How does it happen with no treatment and the face looks class 2, however, the occlusion is class 1? What to do about that? You can assess for yourself from a panoramic view in the mixed dentition from 1992 how much crowding actually exists. How close to an extraction case do you think this is? This patient shows a vertical facial pattern with a mandibular plane angle of 31, a lower facial height of 53, and a posterior facial height of 66. She is noticeably vertical in pattern development, also having a 7 millimeter convexity or 7-degree A and B angle, substantially class 2. How would you be thinking of treating this case? Extraction, non-extraction, class 2 skeletal, class 1 dental. If you like the end result of this patient when she's 24 years of age, many years into post-treatment, actually 7 years post all orthodontic treatment, if you like what you see, then you agree with the treatment that was done. Extraction or non-extraction. Aha. I know exactly what you're trying to do now. You're trying to count the bicuspids. How about her face? Does it betray extraction or non-extraction? Do you think she has good profile balance at this age of 24 years? Or would you like to see a different profile balance? Smiling profile. Do you think she has good dental facial balance in this view? If so, you agree with the treatment that was done. You will see this patient in appointment-to-appointment detail. That will not be the only extraction, non-extraction case we will look at. We will also take a look at this particular patient. This girl is 7 years, 6 months of age. Make an assessment of her facial balance from a frontal view, from a frontal smiling view, from a profile view in facial balance. What would you prefer to see for a 7.5-year-old Caucasian female? Or do you think she has good facial balance? Her smiling profile, well, you can tell her upper incisors, if you look carefully, are rather upright. Her occlusion, well, interesting. Make a decision. Is her posterior occlusion class 1, class 2, asymmetric class 1, 2? How much crowding do you actually feel is in the case? Take a look at the crowding of the upper laterals, the fully rotated lower right lateral incisor, the size and shape of the developing permanent teeth, class 2 asymmetry. Examine the lower arch crowding. Do you think this case should be treated extraction or non-extraction? We will have a brief discussion about her cephalometric pattern and facial analysis. How would you be thinking of treating this case? What would be the treatment sequence? You will see this patient in appointment-to-appointment detail. I will have a detailed manual for all Friday participants. This girl was treated in 2 phases. The second phase of treatment was only 18 months in length, start to finish, with full fixed appliances. The first phase of treatment, how was that done? Was this an extraction or a non-extraction case? If you like her facial balance after treatment and in post-treatment, then you agree with how the case was treated. Do you think this was extraction or non-extraction? If it was non-extraction, how was it treated? Appointment-to-appointment detail will be important. Asymmetries in the mixed dentition. Again, the description that you are looking at is specifically for the Friday, June 26th main meeting. We are having a meeting Thursday for a half a day, as well as Saturday for a half day. However, those are limited attendance sessions, and I am not certain if space is still available. You will have to contact the OVAP central people to find out if space is still available. Another case that we will look at is a 7.5-year-old female. We'll have OVAP teams to discuss her facial balance and analysis. Are you happy with her profile as a 7.5-year-old? What effect will extraction versus non-extraction have on her profile? Intraorally, what do you see? What do you see? Well, certainly you wouldn't miss this rather substantial frenum on the maxillary arch or the fragile zone of attachment at the lower anterior. Is that zone of attachment fragile enough to require a gingival graft correction? Do you think that she will require a frenectomy? Do you? Frenectomy, lack of zone of attachment at the lower anteriors, gingival graft, how likely is it that that will need to be done? Posterior occlusion on the right side shows class 1 canines. Does she have upper lateral incisors? If she has developing upper lateral incisors, are they developing normally? You can see a completely blocked out lower left cuspid, severe midline shift to the patient's left, tapered crown morphology. What do you see on the panoramic film? Yes, what do you see? Of course, you notice the pegged laterals with 0 root formation. Will she develop roots? If so, will they be normal? How about considering the angulation of her canines? The upper right canine in its angle of emergence, and the upper left canine in its angle of emergence. How would you be thinking about treating this case? What advice would you give the parents? Extraction, non-extraction. Will the laterals develop normally? The history here is the mom has a pegged lateral and also a missing lateral, and she is not happy with her anterior dental aesthetics. And if you saw this patient's mother, you would understand why she's not happy. She tells me she does not want to have this same scenario happen to her daughter. Perhaps you're thinking about extracting the lower right cuspid. How many of you have actually done that? Remove the lower right cuspid and then hoped for a shift to the right. Have you tried that? Has that worked out for you? Because I assure you I have tried it. I can also assure you this has not worked out for me. The girl's face clearly requires non-extraction. How would you use simplified orthodontic mechanics with fixed appliances to quickly and efficiently get to this position? This is the same patient. Very simple, very efficient mechanics using simple arch wires and mechanics that you already have in your office. You will not need to buy anything new to achieve this. Of course, one of our key issues in orthodontic treatment is, will the case be stable? How will this patient look 9 years out of all orthodontic treatment with no fixed lingual retention? Look carefully. What do you notice? Well, certainly you notice that the upper right lateral has been restored. That's a natural tooth. It was restored many years ago. What else do you notice? Well, I think you also notice that there is no frenectomy, no gingival graft. Were you expecting that she would require a gingival graft or frenectomy? Many of us would have thought that was going to be indicated. Clearly treated non-extraction. In facial balance, if you agree with her facial balance and what you just saw in her occlusion, then you agree with how the case was treated. I will be showing this with hands-on mechanics in very, very interesting appointment-to-appointment detail. Again, are you happy with her facial balance? Because if you are, in this 9-year post-treatment view, no fixed lingual retention is being used in any of these cases, then you would be interested to see how the case was treated. How do you think it was treated? Class 2 treatment in the mixed dentition. Indications for Class 2 treatment. Here's an interesting 7.5-year-old fellow. Facial balance from a frontal view. Let's look at that more carefully. Frontal balance view does not appear to be objectionable. Smiling, well, obviously some mixed dentition appearance. Ooh. Profile. Face looks substantially Class 2. How would he look with his mandible postured forward? Much, much better. Much better. So this would simulate a mandibular posturing or mandibular growth device. That looks quite desirable. Perhaps some sort of twin block, bionator, activator, Frankel appliance. Notice the uneven gingival heights of his centrals. Some difference in crown morphology. Obvious crowding on the lower right side. So if you look carefully, you'll notice the lower right primary cuspid is missing. You're seeing a lower right lateral against a lower right first primary molar with obvious crowding. I'll give you a moment to study this. Obvious crowding on the upper and lower right sides. Crowding at the lower left first bicuspid. Cephalometric analysis, again, we will discuss this efficiently but in necessary but brief detail during our Friday meeting. How would you be thinking of treating this case? Perhaps taking out upper bicuspids only. Perhaps upper bicuspids and a lower anterior tooth. What advice would you give to these parents? How do you think the case was treated? This is first phase treatment only. He never received a second phase of treatment. I did recommend a detailing and finishing phase, but that for this family was not financially feasible. Middle picture is progress. Then you notice the picture in the lower right, which is post-treatment. Profile. Interesting. Look at the red arrow with mandible postured forward, and then look at the lower right-hand corner in the finished profile as of 2010. It appears I made his mandible grow. How do you think this case was treated? Extraction, non-extraction. How was the Class 2 treated? How was the asymmetry treated? And again, I will show this in detail that you will be quite pleased with. You'll notice the patient certainly has a residual deep overbite. However, the right side has showed nice Class 1 correction. This does not happen by itself. I'll be showing you the literature from Bishara that Class 2 posterior occlusions do not self-correct. Now, if they do, it is extremely rare and exceptionally unpredictable. This is treated in the mixed dentition only. There was no detailing and finishing in the permanent dentition as selected by the parents. How was this asymmetry corrected in the first phase? This was very efficient treatment, both in mechanics as well as in a timely fashion. These cases will be shown June 26th at the OVAP meeting. I will attempt to show all of these cases as time allows. As time allows. Of course, I'm looking forward to seeing you with this very interactive OVAP group. I had a wonderful experience with you last year. Therefore, I'm looking forward to this year's meeting. Here is an 8-year, 9-month female with 9 millimeters of overjet. 9 millimeters of overjet. You'll notice from a frontal view the lip strain in order attempting to get her lips closed. Profile view, that's her lips at repose. Here she is trying to place her lips together and posturing her mandible forward. Not a very good facial appearance. The parents are very concerned about this aesthetic appearance of their daughter. They're very concerned about the amount of teasing and bullying that's happening at her school. How would you be thinking of treating this case? Blocked lower cuspids, pegged upper laterals. What do you think about the root morphology of the upper anterior teeth? Are you concerned about root resorption in this case? Extraction or non-extraction? If you think it's an extraction case, which teeth would you propose to extract? The cephalometric analysis on this patient will include my feelings about the aesthetic balance and dental facial balance of the upper and lower incisor positions. Think, how would you advise treating this case? What advice would you give to the parents? They are exceptionally enthusiastic about treating as soon as possible. How would you advise treatment proceed? Here she is in progress, 9 months in the mixed dentition phase of treatment. 9 months of treatment with exceptionally simplified mechanics. At this point, she's nearly 12 years of age. Here is her facial balance after the mixed dentition phase of treatment. Comparing time 1 at 8 years, 9 months of age to time 2. Again, the mixed dentition phase of treatment, start to finish, was 9 months. She does not have her mandible postured forward on the right side. This is the girl in repose or relaxed position. How do you think this treatment was achieved? What treatment options would be useful to you in the mixed dentition? She did have a very limited finishing phase of treatment, which lasted 10 months total. That's 10 months in the permanent dentition. Here, as you'll notice, she's 12 years, 8 months of age. Obviously, the face has become far more mature at this point. Extraction or non-extraction? These are some of the cases that you will be looking at our meeting with OVAP. June 26th, the main meeting on Friday. As mentioned, there will be limited attendance sessions on the 25th and 27th of June. Contact OVAP for details. I'm looking forward to being with you again June 25, 26, and 27 for another festive session. Again, we would like to recognize the sponsors of the OVAP meeting that will be attending. These are people that support your organization. Please support them.